Yes, it's good. Yes, we are live now. Hello, everyone. Welcome back to another virtual dental shadowing session. Today, we're joined by Dr. Amanda, who is a pediatric dentist. Thank you for joining us today, and feel free to take over whenever you're ready.
Awesome. Thank you. Thank you to Virtual Dental Shadowers for having me today. I'm excited to be going over pediatric dentistry, what it's about, what we do, and then I do have a few little cases that I'll be going over with you today. If you have any questions, feel free to reach out to me. I'll include my contact information at the end as well. So just to start, I do have to give a few financial disclosure. I am an ambassador for a few of these companies, and my presentation is for educational purposes only. No duplication should be made, and I did get consent from everyone to do this presentation. So first, I'll be starting with just a little bit about me and kind of my journey to how I got where I am today. So I'm Dr. Amanda. I am a board certified pediatric dentist in the Bay Area in California. And I've wanted to be a dentist since I was 14 years old, so for a very long time. I always enjoyed science, and I have always had a passion for working with children as well. And so those kind of two things were kind of what drove me to want to be a pediatric dentist. I always volunteered at pediatric events in high school and even younger. I started babysitting when I was probably 12 years old. And I have two younger sisters as well. So those are kind of the framework or my foundation for what kind of led me here. And then throughout college and dental school, I did participate in a lot of events that confirmed that I did want to specialize in pediatrics specifically. So February is actually Children's Oral Health Month, which we're celebrating right now. And last week was Give Kids a Smile Day, but it is celebrated and people participate in the event all of the month of February. And so it can be a practice, it can be multiple practices, it can be led by the state. But Give Kids a Smile are events where we provide free dental care to children. So I started volunteering at these events all the way back in high school. And I had a lot of fun working with the kids at those events. And then California Dental Association does CDA Cares, which is providing free dental care to anyone in the community, not just children. But I was kind of drawn towards the pediatrics area at these events as well. And once I got into dental school, I did have the opportunity to do 2 different dental mission trips, which I highly recommend doing if you have the opportunity in dental school or even afterwards. So I went to Jamaica and then I went to Fiji, and it's just a week long where you go to these remote dental clinics. There's limited power. There's lots of things that you're trying to work with or without. But it's all about just providing care to these people who don't have access to a dentist. And we're helping the community, but honestly, I got a lot out of it too from doing these mission trips. So that was a really great experience. And then towards the end of dental school, I did an externship at USC and Children's Hospital Los Angeles as well. So I was able to see a pediatric dental program firsthand, which I do recommend if you're considering different specialties, or if you want to specialize or even do a GPR or AEGD program. If you can shadow and do an externship, I really recommend that as well. Okay, so a little bit about my education. So since I knew I wanted to be a dentist from a young age, I was really interested in the UOP accelerated dental program. So I was accepted as a 2+3, which is where I would have done 2 years of undergrad and 3 years at dental school. But a lot of my mentors advised me to do it the 3rd year of undergrad. And I'm really glad I did, because I was actually able to study abroad for a semester in Italy. So just like you're in Spain.
Wow.
It was a really great experience that allowed me to see the world before I really had to buckle down for dental school. So I was really happy that I took that 3rd year and I got my bachelor's, and I was a biology major. And then in dental school, I believe it's still the only accelerated dental school. So I did dental school in 3 years. And then after that, I was accepted to Cincinnati Children's Hospital. So I moved out of California for 2 years, and I had a great experience at my pediatrics residency. It was in a hospital program. So it's very hands-on. You're seeing patients all day long. And then we were on call as well in the emergency room seeing dental trauma. So I got so much great experience there. And then when I graduated, I came back to the Bay Area where my family is. And I started working in private practices. And I also volunteer at Dugoni Dental School at their pediatrics clinic occasionally. And I really like being able to get back to my dental school that way. So in case I run out of time, I like to put my advice for pre-dental students towards the beginning, just so I can make sure I can give you these little tidbits that I've kind of picked up over the years. So yes, your GPA and your DAT scores are important. I did the Kaplan prep and cracked that PAT. I'm sure there's probably other resources out there now too, but that's just what I did when I was studying. And I'm sure most of you, if you're pre-dent, you already have good study habits, but the reason I say that is just to really make sure that you're conscious of what study habits work well for you, because in dental school, you won't only be studying for these tests and for classes, your didactic classes, but you'll also be spending time in the simulation lab. So you'll kind of have to break up your time that way. So you want to make sure you kind of have that figured out before you go into dental school. And then if you can, I really recommend volunteering and participating in extracurriculars. I was reading some stats, some program directors, if they spend 10 minutes on your application, they'll spend 2 minutes of it just looking at your hobbies. And it's because they want to make sure that they're inviting people into their program that they're going to get along with and that they are kind of good people all around. So definitely make sure that you're finding those hobbies and those things that you like to do outside of dentistry and school as well. My next one is make sure you're shadowing different specialties and at different offices. I think if you're not sure what kind of dentistry you want to go into, the specialties is really important. But even within different offices, there's a lot of differences. So whether it's a clinic or a private practice, is it a DSO? Is it a small boutique practice? And it can kind of give you an idea of if there's any sort of specialty training you want to do or what kind of practice you're working towards after you finish dental school. And then by expand your horizons, I mean, study abroad, travel, network, hang out with your friends, do that externship, do those things that you're not sure if you want to do, but you may not have the opportunity to once you're out of college. So definitely take that time if you can to kind of get a broader view of the world, because you never know what those connections will bring to you in your practice as well going forward. And then this one is one that's really important for dentists. I did not realize how physical dentistry was on your body. So self-care is really important. So taking that time, whether it's stretching or yoga, meditation, drinking water throughout the day. I know a lot of my colleagues and it's hard to drink water when you're wearing an N95 mask all day. So, even basic things like that, develop those good habits now so that you don't get burnt out in dental school or in practice later on, because I know I don't want to just be in practice for 5 years. I want to have a long career. I love what I do. And so a big part of that is being able to take care of myself so that I can take care of my patients as well. So I really recommend that for you guys as well. Okay, so sustainability in dentistry is something I'm really passionate about. So I had to put a little bit of that in here as well. Green dentistry is an approach to dentistry where we're reducing the dental practice's environmental impact or carbon footprint. So this means that your service model, you're not just considering the patient, but you're also considering how it impacts the planet. And you can do both. You don't have to sacrifice your quality of care. You can still provide a high level of care while caring about the planet. Sustainability is definitely something that's newer, at least in America, in the field of dentistry. But I'm hoping in the next 5 years, we're going to be seeing a lot of innovation in that area. So hopefully when you're in dental school, that's going to be a really big aspect, and you'll be able to practice with sustainability at the core of your practice. So this is a little bit about why sustainability is important in dentistry. So this is just looking at just toothbrushes in America, so only one country. 1 billion toothbrushes are estimated to be thrown away every year, which would wrap around the earth 4 times. And we know that plastic does not ever disappear. It just breaks down into microplastics that end up in the ocean, the environment, and our food, in our bodies. So we definitely want to start moving away from plastic as much as we can. So right now, the best alternative is a bamboo toothbrush, which would prevent 50 million pounds of toothbrushes from going into landfill each year just in America. So even if you recommend a bamboo toothbrush to your patient, you're making a really big impact on the planet, or even if just you switch to a bamboo toothbrush. And then I think the pandemic really highlighted the waste that comes from PPE, specifically with face masks. They estimated 129 billion face masks were disposed of every month, which is a lot. And so millions of them are unfortunately ending up in the environment. So my little PSA, because currently you can't recycle them, right, is to at least cut the ear loops when you're disposing of your mask so it's not getting caught up in little animals too. Okay, so I wanted to go over what a typical day looks like for me. Again, every pediatric dentist can schedule their patients a different way. But I think a lot of people get surprised when they see a pediatric dentist schedule because we do see a high volume, high amount of patients every day. It's probably only less than what ortho would do in a day. So right now I'm working 4 days a week, 1 Saturday a month, and this gives me the opportunity to volunteer at the dental school on some Fridays. And in my practice, there's about 4 or 5 pediatric dentists at any time. So we do rotate call monthly. Because we're private practice and not at a hospital, knock on wood, our call is not as busy as when I was in residency, but we are available to our patients 24 hours a day. And then as a pediatric dentist, I can also do general anesthesia cases with an anesthesiologist who comes into our office. So we usually do about 4 cases on those days. So this is for my special needs patients, my patients that have dental anxiety, or patients that are even just too young to understand what they need to do in order to have safe dental treatment. So they would be completely sleeping and I would do all of their dental treatment that's needed. On average, it takes about 2 hours or less. And when they wake up, all their dental work is fixed. So we do provide that option for our patients. And then we start our day off with a huddle so we can point out anything, any specific medical alerts we need to be aware of, any patients that have called with questions or any office visits, why they're coming in that day, just anything we need to all be on the same page for. And I also like to review my patients at least a day prior. I usually start the week before, and then I'll touch in again the day before because I like to know what I'm walking into. And some patients, we do have to give pre-medication antibiotics and things like that, reminders not to eat before their appointment if they have a gag reflex. So there are certain things you want to be prepared for and talk to the patient about before they come in. So as you can see from the graphic, on average, I see about 4 columns of patients each day. So that first column you're seeing is scheduled at an hour per appointment. So that's typically my treatment appointments. So crowns, fillings, extractions, space maintainers, things like that. And then the other 3 columns are for our continuing care visits or new patients, and also if we have any emergency visits as well. We do schedule closer to an hour for our new patients because there's a lot of education that goes into those first visits. And we want to make sure we have enough time to answer their questions as well. Okay, let's see. This is a video, it's loading, so hopefully this will work. So this is a little tour of one of our offices that we have. So this is our front desk area. We have 2 doors. One is the little one for our patients. They love going through that red door. We do have a private consultation room and some quiet rooms for treatment. So it's a closed door room. And then we do have our open bay with benches, and this is where we do most of our cleaning appointments as well. So as you can see, it's a pretty large office, and we do have 3 offices for the practice that I work at. Okay, so a little bit, I mean, pediatric dentistry, it's an age-defined specialty, so it's kind of self-explanatory, but we do provide primary and comprehensive preventive and therapeutic oral care for our patients, usually for infants through adolescents, but by 12, 13 years old, you do have most of your adult teeth. So depending on what dental needs they have, sometimes we do have to graduate them to a general dentist starting at that age. But some of our patients will see them through college because they don't want to leave. So sometimes we'll see 21, 22-year-olds too. Usually they just outgrow my chair, and that's when we kind of have to move them on to the next office. But during my 2-year residency, I do receive extra training in child development, special healthcare needs, behavior management, all 3 levels of sedation, as well as interventional orthodontics as well. We do have an orthodontist in our practice, so we work really closely with her, but it's really good that I got the orthodontics training so I can know what she's doing and when she wants me to refer patients and things like that as well. So in my comprehensive examination, I'm going over a lot of different things, definitely addressing any chief concerns that they may have. And then I'm doing a full examination of their head and neck region, starting with the extraoral, looking at the TMJ joints, moving inside the mouth, looking at the gums and the teeth, the tongue, the airway, their bite, and then this little form, you can see this, it carries risk assessment form. So we're going over how likely they are to get cavities and how we can reduce their risk, what they can do at home to reduce their risk. And then something that's different from most other practices is that we do rank their behavior as well, because it's really important when we're doing treatment planning. So we can decide which mode of treatment would be the safest for them. For diagnostic tests, so we'll go over the patient history, and since I work with children, usually that's the parent giving me that, although sometimes the patient will tell a different story from the parent, which is also helpful, because sometimes the child changes what they're feeling when they're talking to the dentist versus mom or dad. We have digital x-rays, which is really nice. It minimizes the radiation that our patients are receiving. And we can also send them to specialists that we're working with really easily. Or if just the parent wants to take them home, sometimes the kids like them for show and tell at school. We'll take photographs. We do pulp vitality testing to see how the nerve of the tooth is doing. Again, that's more difficult in our younger patients. Study casts, which are mostly digital now as well. We have an iTero scanner at our practice. And then, as I mentioned, the caries risk assessment is really important as well. There is a new test that's coming out to test your oral microbiome. So I'll be sharing more information about that soon, but basically it's kind of like a DNA test, like 23andMe, and the patient is going to swab their mouth and get a full assessment of the microbiome that they have in their mouth. And this is going to really help us tailor their preventive treatment plans going forward. So you guys will probably hear a lot about that in the next year or 2 as well. Okay, so what are some chief complaints that I get as a pediatric dentist? The first one that's probably the most common is pain. And a lot of times kids don't know how to express their pain. So it's really hard for parents to figure out what's going on. So it may be something that I'm really used to seeing, but for a parent, it may be brand new and it can seem really intimidating. So sometimes it's from cavities or an infection or swelling, but more commonly, it's usually just from erupting teeth coming in. You start to lose teeth around 6 years old. So a lot of parents are like, whoa, what are those shark teeth that are coming in, as you can see in the picture? So if you have crowding, sometimes this can happen. So we see a lot of ectopic teeth, even canker sores. A lot of parents, the kids won't let them look in the mouth, but they'll let the dentist look in the mouth with the light. And all of a sudden they're like, oh yeah, that's definitely what's causing the pain. So those are probably the more common things. And then, like I mentioned, we do deal with dental traumas for children as well. Okay, so the types of procedures that we do, a lot of pediatric dentistry is preventive. So cleaning, sealants, and oral hygiene instruction. And then for restorative side of things, we do a lot of fillings. Stainless steel crowns is kind of the standard of care. We also can do white crowns and then buildups if a child breaks their tooth. So I'm going to take a drink of water here. Okay, and then we do a little bit of orthodontics. In this picture, you can see we can do a space maintainer, which is a passive appliance. So that's just kind of to hold the teeth in place so we don't lose any space for the adult teeth that haven't come in yet, or a Halterman appliance, which would help with ectopic teeth. Oral surgery is pretty basic for pediatrics. We're either doing extractions of infected or broken teeth, or baby teeth that just don't want to fall out. We can do oral pathology excisions or frenectomies, which is like a tongue or lip tie. And then, as I mentioned, we can do sedation as well. Okay, so I wanted to go over some terms that are a little bit different for pediatrics. So the first is just the numbering of the teeth. We actually work with letters for pediatrics. So you want to start in the upper right, go to the upper left, go down to the lower left, and back over to the lower right. So it goes A through J and down K through T. And then for adult teeth, it would actually be numbers. So starting with your wisdom tooth, 1 through 16, down 17 to 32. Tooth surfaces. So incisal is canine to canine. That's that top surface. And then for your back teeth, the chewing surface on top, that would be occlusal. And then mesial distal is if it's facing the midline, it's mesial, or away from the midline would be distal. And that's kind of like the flossing area. And then the front or the back of the tooth. So facial would be the front of your tooth, and then lingual would be either next to your tongue, or on the top, it would be palatal. And then this little picture here is some basic tooth anatomy. Most of you already know this probably, but the outer layer of the crown or the top part of your tooth is the enamel. The second layer of tooth structure is your dentin. And then the inside of your tooth has the pulp, which is like your nerve and blood supply. Okay, so as I mentioned, behavior rating is really important in pediatric dentistry. So the Frankel behavior rating scale is the most common one that we'll use. So while 1 is a patient that does not want to open their mouth, they do not want to be there, they don't like it, they are not going to help you with anything. Whereas a 4 is, oh my gosh, I love coming to the dentist. I've been so excited to come here all day. I'll help you count my teeth, like whatever you need. So it kind of ranges. Sometimes they can start out as a 4 and kind of end up as a 2, which we would also write in the note. And this just also helps not just with treatment planning, but also with scheduling, because a lot of patients, if they are a little more nervous or they are just tired at the end of the day, we'll actually see them in the morning time, so they're not as tired after a long day at school as well. So I won't go over all of these, but they are in here for you guys to reference. But we have kind of our own language in pediatrics. Obviously, we don't want to reference a shot. That would scare the patient. So we use little euphemisms or code words for these things to explain them to the patient. Tell, show, do is an important behavior management technique that we use, where we will tell the patient what we're doing, show it to them in a friendly way, and then we'll do the procedure. Because a lot of the reason that children are so scared is because they don't know what's happening. It's a brand new experience. And surprisingly, a lot of patients do really well just once they know what's going on. So the nitrous oxide, we call that the silly gas or happy air that they would smell through their nose to kind of help relax them while we're doing treatment. We call cavities a bacteria. We call them sugar bugs. So, and you can make things up too as you go. Sometimes I'll call it sleepy juice when I'm numbing them. Sometimes I call it Elsa's drops because we're freezing the tooth and we're going to make it feel really cold. So you can just kind of make it fun. I'm still working on how to incorporate Encanto into all of this. Okay. So occlusion, that's how the molars come together. So the primary molar relationship with the baby teeth, it can actually help indicate what the relationship of the adult molars will be when they come together. So this is something we're constantly assessing so that we can determine if we're going to need to refer to the orthodontist or not. So the first one is a distal step. So you can see that the bottom teeth actually almost go behind the top molars. And a lot of times we'll see that turn into an overbite or a class 2 malocclusion, which would indicate that they would likely need braces in the future. A flush terminal plane is where those back molars are completely in line with one another. Usually this can turn into a class 1 occlusion, which is what we're looking for. But again, it can change. So we just kind of monitor as they're growing and developing. A mesial step is where the bottom molar is actually anterior to the top molar. So this can either turn into a class 1 occlusion, or sometimes if it's an exaggerated mesial step where it's a lot more significant, it can even turn into an underbite. So again, it's just something we have to monitor constantly with their growth and development. Okay, so I'm going to go over some case presentations now. And again, if there's any questions about anything, I'm happy to answer those as well. So not the best pictures because we work pretty quickly in pediatrics, but my assistants were able to take these for me so I could kind of show you what our general treatment setup would be. So in the upper left, you can see I do have the nitrous nose that will attach to the nitrous oxide hood. And that's what the patient will smell through their nose to relax them while we're doing the dental treatment. You can see the local anesthetic there. And then also that's a dry shield that we have, and it works really well with my patients because it has the suction, it has the bite block to help keep their mouth open. And a lot of times the noise from the suction also kind of helps relax the patient because they have that and they're watching a movie. So a lot of kids, once we get everything in place, they're not even aware of what's going on, and you can just get everything taken care of. On the bottom picture, you can see kind of my burr block setup. So the burrs are, I use different ones depending on what kind of procedure I'm doing. And then just a basic setup. So a mirror, explorer, and the cotton forceps. We have those with every setup. And then the topical jelly on the right side. So in pediatrics, it's most people I know use topical first because it kind of pre-numbs the area, which makes the local anesthetic delivery a lot easier for our patients. So definitely, if you ever have to go to the dentist, I would recommend asking for that as well. Okay, and so in the left picture, again, you can see we have our air water syringe, our high-speed evacuation, our low-speed suction, and then we also have our high-speed and slow-speed hand pieces, and then another air water syringe. So kind of one for my assistant and one for me as well. And then on the bottom picture, there's a lot going on. So I'll kind of do an overview for you. But we always have the floss so that we can check the contact and everything after we're done with our procedure. On the very top, that's a glass ionomer delivery system. So sometimes we'll do that if we have to do a temporary filling or if we don't have good isolation, which sometimes can happen for pediatric patients. And then I'm going to jump down to the lower right. So the first syringe on the left, the green one, is Limelight, which is kind of a liner that we can put if we're getting close to the nerve or even just to help with sensitivity in the tooth. The blue one is our etchant, which helps prepare the tooth to receive the filling. And then the other two, those are flowable composites. So they're a little bit more viscous when we apply and not as putty-like as the composite gun, which is on the left-hand side. And then the little wells that have the kind of light shield on them, we'll put the bonding agent in there. So we would do that after the blue etchant and before we put the filling material in place. And then also when we're doing crowns, we will have to put IRM, a temporary cement, inside of the tooth to kind of help heal it from the large cavity. And then we also, in my practice, we're still doing formocresol for our pulpotomies. So again, it's a type of medicine to help seal the pulp. It's almost like, it's not a full root canal, it's just a root canal almost of the top part of the pulp chamber. So that's what those little pellets are. And then we mix those two components together to make the IRM as well. Okay, so my first case, this was a healthy 4-year-old that I was seeing. I think this may have been her first time that we were doing treatment for her. So we were actually fixing cavities in her lower right quadrant. So our treatment plan, we were going to give nitrous oxide. She's only 4, so the nitrous oxide we usually recommend for that age. It really helps relax them quite a bit. We are going to do a filling on T. So again, that's that very last baby molar in the lower right because the cavity is a little bit smaller. And then we did have a pulpotomy and stainless steel crown planned for tooth number S. You can see that cavity is a lot bigger and it's very close to the nerve. Typically, when it's that close on an x-ray, it does extend into the nerve when you open the tooth up. So we always, if it's kind of questionable, we'll always plan the crown, because if it doesn't go into the nerve, a parent's much happier to hear that, oh, we're just going to do a filling instead, versus if you get in there and you told the parent it's a filling and then you have to change it to a crown and pulpotomy. It's a little bit more surprising for them. So I always recommend plan the crown just in case if you're not sure. Okay, so I do have little diagrams. I'm going to go into a little bit more detail about the actual crown procedure, because I don't know, you guys have probably heard about fillings before. So with a pulpotomy and stainless steel crown, we do have to prepare the tooth to receive the crown. So this means removing enough tooth structure that our crown is going to fit onto the tooth well. And we also don't want it to change the occlusion or their bite at all. Again, the nice thing about baby teeth is the kids are growing and their mouth is changing. So a lot of times they'll get adjusted to the crown pretty quickly. With the pulpotomy procedure, we'll go in with our slow speed burr, like you can see in figure 1. And what we're doing is once we remove the cavity, we're also cleaning out that top part of the pulp chamber. You'd notice we are not going into the roots at all, the bottom. Then what we're doing, you can see in figure 7 here, is we're putting those formocresal pulp pellets inside of the pulp chamber. And what we're doing is we're hoping to get hemostasis or stop the bleeding. And that's how we can kind of tell if the pulp is healthy enough that we can then finish the procedure as intended. If it's not, sometimes we actually have to take the tooth out instead. So, but the x-ray looked pretty good for this one. So it did work out. We were able to get hemostasis, and you're looking for the fixed root stumps, or we call it the black eye stage. It looks like 2 little black eyes when you take out the formocresal pellets. And then, as I mentioned, we're mixing those 2 components together of the IRM to fill the pulp chamber. Okay. And then once we have the IRM in place, we just glue on that stainless steel crown on top as well. And then we'll do flossing, a good rinsing. We want to remove all of the excess cement around the outside of the crown as well. Okay, so there's the final picture. You can see we did the filling on tooth T, and we did the pulpotomy and stainless steel crown on tooth number S as well. At this point, we've taken out the dry shield. So I would classify her as a Frankel 4. She was really good. She wasn't moving. She just watched her movie, let us do all the treatment as planned. So I would definitely recommend doing the nitrous oxide for her next treatment as well. And then the post-operative instructions that I give the parent. So she is going to be numb for about 2 to 3 hours. We recommend biting on gauze for at least the first 30 minutes while she's kind of realizing that her lip and her cheek are still numb. With children, we have to be really careful so she doesn't bite her lip or her cheek. A lot of kids will scratch, or they're going to bite their lip and they won't even know that they're doing it. And then they're going to have a pain for a week or 2 afterwards. So that's really important for postoperative care for patients. And then just over-the-counter children's Tylenol or Motrin as needed. Some kids are a little bit sore, but most don't need it after a standard dental treatment like this. We do recommend flossing, waiting to floss or eat any sticky foods right away. We want to let the crown kind of settle, the glue dry as well. And we don't want them to pull that crown off either. We also want them to watch for signs or symptoms of infection. So if there's any pain or swelling in the area, unfortunately, pulpotomies do not have a 100% success rate. It is in the 90s most of the time, but again, it's not 100%. So we just want parents to let us know if there's any pain or anything going forward. And then we give them our contact information as well to answer any questions going forward. Okay, so this is the second case that I'll be going over today. So this was an older patient. This was an 8-year-old healthy male, and he was referred from another dentist because he developed an abscess in the lower left quadrant. Okay, so we can see he's already had dental treatment before. He had, similar to my last patient, he did have a filling on that back second molar and then a pulpotomy and stainless steel crown on the first baby molar. But instead of on the lower right, this is on the lower left. Okay, so we can see radiographically and clinically what the abscess presented like. So on the x-ray, we can see that radiolucency that developed, that little dark area. And then clinically on the bottom, you can see there's an actual, like, it almost looks like a little pimple on the gums. So that's how the parent first saw it and brought them into the dentist. So my treatment plan was to give nitrous oxide. I do recommend that for extractions because even though we're giving numbing medicine, sometimes they can feel a little pressure from an extraction, which a lot of patients don't like. So the nitrous oxide does help with a lot of that. And then because we're taking out a baby tooth early, we do want to put a space maintainer in, which is really important so we don't lose space for the adult tooth as well. Okay, so this is kind of what it looked like while we were in there. So we did put him on nitrous oxide. We did about 40%. So that means 40% nitrous and 60% oxygen. And then we did our topical and local anesthetic delivery. Once we kind of let that settled, we did do the extraction of that baby molar, which you can see on the bottom. And then what we did is we fit the bands on the adult first molars, which this patient is over 6 years old. He's 8, so his adult molars in the back have already grown in. So we can do a bilateral space maintainer, meaning it goes on both sides because we do have those molars in. So we fit the bands and then we'll take an impression like you can see in the top picture there. And then what we do is we'll send this to the lab to have them make the lower lingual holding arch for us. So these are just some photos, some different types of space maintainers that can be done. Like I mentioned, we did the lower lingual holding arch, which is that second photo. So what's nice about that is it can be done if you have to take out one tooth, or it's really helpful if you have to take out more than one baby tooth, that holding space. If we only have to take out one baby tooth, a lot of times we'll make a band and loop because we can do that chair side as well. So we don't have to send it to the lab. And then the distal shoe is good as if only one tooth is removed, and we also don't have to send it to the lab. And this is to be used if you're taking out a second molar, but the adult permanent first molar has not grown in yet, because we want to make sure that the adult molar is not growing in where that baby molar was to begin with. So that's really helpful. So hopefully they may not have to have braces to fix that later on as well. Okay, so this is a picture I showed earlier, but that's kind of what the lower lingual holding arch will end up looking like when we get it back from the lab. It takes about 2 to 3 weeks, so it's enough time for everything to kind of heal, and we'll have the patient come back so we can just glue the space maintainer on. So this patient was able to get everything done as well. He was a Frankel 4, I would classify him as well. Very similar postoperative instructions to bite onto the gauze, avoid lip and cheek biting, Tylenol or Motrin as needed. We gave our contact information, but the two differences for an extraction is definitely make sure to come back so we can deliver that space maintainer. And I always like to mention that saliva and blood can mix together and it can look like a patient is bleeding. So definitely once you kind of wipe it out, take a look. A lot of times the patient is not actively bleeding, but we do say if they do seem like they're actively bleeding, always just give us a call. It's better to be on the safe side rather than letting the patient continue to bleed. Okay, and then I have some different new technology I'll be going over. A few of them I've mentioned already. The first one is that dry shield isolation. Again, I really like that one for children because it's kind of 3 things built into one. So it reduces the number of items that I have to put in the child's mouth. Sometimes it doesn't work great for patients who have a really small mouth because they only have so many sizes. And also for children that have a gag reflex that's really strong, sometimes they can't tolerate that. So we do have other options as well. Silver diamine fluoride is amazing and so helpful for a lot of our patients who can't do dental treatment yet, or they may just be starting to get a cavity. And so by applying this medication, we can actually arrest or stop the cavity from growing. So sometimes we don't have to fix it, or sometimes it'll just buy us some time until the child's a little bit older and more cooperative. And then we can go in and treat it without having to do any level of sedation for the patient. So that's a great new option that's been out for a few years now. Hydroxyapatite is finally coming to the market and gaining more popularity. The studies are showing it's actually as effective, if not more effective than fluoride, which is awesome, especially for younger patients where we worry about them swallowing too much of the fluoride and getting fluorosis, which is like the white spots on their adult teeth, or getting an upset tummy. So that's a really great option for a lot of patients as well. So this is kind of a more in-depth photo that you can see what the dry shield looks like when it's in the patient's mouth. So I'm actually able to isolate 2 quadrants of the mouth. So it's pulling out the cheek, it's removing the tongue, it's also protecting the airways so nothing gets dropped. It's doing the suctioning, and it also has that bite block built in. So again, really, really helpful. The other options we have are either cotton roll and dry angles that we can use to kind of block everything. But again, that's 2 separate components that we then have to maintain, or the traditional rubber dam. But I do have to give more local anesthetic in different areas. So that's more injections, which is harder for some of my patients. So the dry shield, I don't have to numb in as many places. So I try to use that as much as I can. So a little bit more about the silver diamine fluoride. It is a 38% silver diamine fluoride, and it's a topical antibacterial and remineralizing agent that can arrest cavities in primary teeth. So originally they were using it for tooth sensitivity, and then they found out, oh, this is also helping to arrest cavities. So let's use it for that as well. So it's great for senior citizens, older patients who can't get a lot of treatment. And we've also found it's really helpful for younger patients. To be completely honest, they don't love the taste of it. It's kind of like licking pennies. And it doesn't eliminate the need always for treatment after as well, but it does buy us some time, which is really helpful. Hydroxyapatite, so just a little bit more detail about it. It is a form of calcium, and it actually already makes up 97% of your tooth enamel and 70% of your dentin. So what that means is it's biocompatible with your teeth. And so when you're remineralizing your enamel, there's no side effects to it, okay? And you're replacing it with what's already missing. So it's a really great option. And the high amount of hydroxyapatite in your enamel is what makes your teeth so strong. So by replacing it with hydroxyapatite, that's actually a really great way to remineralize your teeth. And even though America's only been getting it in the past few years, it's been in Japan for over 40 years, just like silver diamine fluoride was, but we're finally catching up and we have more options for that here. Okay, so I mentioned a little bit about the stainless steel crowns. We do also have the zirconia crowns, or the porcelain ones. So I like to do those definitely on the anterior teeth, usually during my general anesthesia cases, because they are much more technique sensitive. We have to have really good isolation. So it's pretty rare that I'll do that on a patient who's not under general anesthesia. And something that gained a lot of popularity during the pandemic was Hall crowns. So it's still a stainless steel crown, but the procedure is a little bit different in that there's no aerosols and we don't have to numb the patient. We're not removing any of the cavity. We're actually just sealing out the bacteria by placing the crown on top of the tooth. We just have to put little separators or rubber bands in between the teeth before the procedure. So this is just another photo of the stainless steel crown. And so the stainless steel is made of chromium, cobalt, and nickel. So you just have to make sure that the patient doesn't have an allergy to any of those metals. But the nice thing, and why stainless steel crowns are kind of the standard of care in pediatrics, is we can adapt it to the tooth in the same appointment, which means that we don't have to send it to a lab, and it saves the patient from having another appointment, which is really nice, versus with a lot of adult crowns, unless you can print it in office, you would have to get a temporary crown put on. And then this is just another explanation of the Hall technique, which I went over. Zirconia crowns, again, you can just see the different shapes for the incisors, the canine, or the molars. Obviously, they are more aesthetic because they are white, but you do have to remove more tooth structure to put them on, so they're not as conservative. And they're also not as durable to bruxism, and a lot of patients grind their teeth. So we do want to make sure that we're choosing our candidates appropriately if we're going to do these zirconia crowns. Okay, and then just a few little tidbits I'll leave you guys with here at the end. Because I'm passionate about sustainability, I do like to encourage everyone to incorporate at least one sustainability practice in their life or their practice if they can, because it's going to go a long way in helping to reduce our carbon footprint here on our planet. You're probably already doing that if you have a reusable water bottle, or if you already have a bamboo toothbrush, or you take the bus. There's so many ways that you can be eco-friendly. Like I kind of touched on earlier, remember to take care of yourself and your health. In order to be a healthcare provider, you have to make sure you're filling up your cup first so that you can provide the best care for your patients. And then just remember that dentistry is a journey, and it includes lifelong learning. There's lots of new exciting things that are always coming out in dentistry. So it's really exciting to always kind of follow along with that along the way. And then I do like to talk about listening to our patients, especially my pediatric patients. Sometimes, like I said, they tell us things that they didn't tell their parents, and then they come in, they're like, wait, your tooth hurts? How come you didn't tell me? So our job is to listen to our patients, and we don't want to just treat the teeth. We want to take a personalized approach. And that's one of the reasons I love working as a dentist, is we really get to know our patients. And for me, I get to see my patients grow up, which is really exciting. We see our patients much more often usually than even doctors do. So it's really important we form that connection with our patients to provide that comprehensive care for them. And the oral systemic connection is being talked about a lot more. So we really want to take that into consideration with our practice. And then lastly, just remember that every dentist has a unique path, okay? Collaborate with your peers, stay connected with your mentors, but whatever area of dentistry you want to go into, there's a spot for you and you will get there. All you have to do is a little bit of hard work and just stay motivated along the way. Okay, and there is a sustainable dentistry Facebook group. So if that's something you're interested in as well, go ahead and look us up on Facebook, and we share different ways that you can practice dentistry with as low of a carbon footprint as possible. And then I just wanted to end with my contact information here. You can find me on Instagram, TikTok, in the Sustainable Dentistry Facebook group. And then this is my link in bio. I do have a lot of products that I talked about and things like that, with some discount links if you want to try those out. But like I said, feel free to reach out in any part of your journey. I'd be happy to answer any questions.
Thank you so much, Dr. Amanda.
My pleasure.
That was a very informative presentation. I have a few questions here for you.
Sure.
So I think you talked about what led you to pediatric dentistry was because of your passion in teaching children and everything, and your undergrad major was biology. I'm answering the question for you because it's what they ask. And what activities did you do as a pre-dental? You went to like volunteer trips. I think they will find the answers in the slide.
Yes.
Let me see, what other questions did they ask? Oh yeah. When shadowing, what should one do and be wary of so you don't get into the dentist way?
Oh, that's a great question. I think communicating with the dentist ahead of time so you can find out what they expect from you, especially with COVID, you want to make sure that you're meeting all the requirements to safely come into the office. I always recommend, if you are following, especially with kids, a lot of parents are like, who's this extra person who's standing here? Introducing yourself to the patient and the parent so that they know that you're interested in dentistry. Is it okay if I watch while the doctor does their exam or does this crown, whatever the treatment is that the child's receiving? Most parents are happy to let you watch, but sometimes if a child's having a hard time, we may have you just step out. So just talk to the dentist ahead of time, and each office will be a little bit different.
And what was the experience of the accelerated program? Because I from what I know, it's a very competitive program. Would you talk a bit about that?
Sure. So I was very fortunate because I got into the accelerated program from high school. I kind of knew what GPA and DAT and all the scores that I had to get in order to get the interview. I know there are some accelerated programs now where the undergrad is cut short and dental school is still 4 years. But if you get accepted into the program, you don't have to interview for the dental school. So I believe those are pretty competitive as well. But again, if it's something that you want to do, just be yourself, try your hardest. And if it's where you're meant to go, it'll work out. And like I said, remember, everyone has their own path to dentistry. So even if it doesn't work out that you're in an accelerated program, you can still be a dentist at the end of the day. Looking back, like I kind of mentioned, there was definitely, we were in the simulation lab day one at Dugoni, but I'm a very hands-on learner. So that was really important for me. So again, I was fortunate that the studying, I could kind of balance my time there. I do know my friends who were in the 4-year dental schools, they did have more time for activities and for studying, that they could kind of spread it out a little bit more. So that's why I recommend having your self-care routine and your study habits and everything lined up before you get into dental school, so that it doesn't seem as overwhelming or stressful as well.
So the accelerated program was beginning in high school.
So I applied for it in high school, and so I got in. So starting my first year of college, I was already in the accelerated program.
Wow, that's amazing. And would you say it's a little bit late if they applied during the undergrad? Or
I think you can still apply to the dental school
Mm.
portion, even if you're in college. I think the accelerated program, though, like if you're going to do 2+3 or 3+3, that you would have to apply for starting from high school. But you can still apply for the 3-year dental school program as well, even if you're in post-bac. Or I had one of my classmates was 45 when he started dental school.
Wow.
So you can apply to the 3-year dental school program at any time. You just have to meet the requirements. So you can go to any college to apply to Dugoni.
Mm-hmm. And how much toothpaste should a child be using?
Great question. So if they're under 3 years old, we just want them to use a smear size amount, so the size of a grain of rice. And if they're over 3, they can use a pea size amount. So most of the commercials that show that big ribbon of toothpaste, everyone's using too much. I had to teach even my husband about that. I was like, why are you using so much toothpaste? You're just wasting it. So that's definitely something that you guys can share with your patients as well.
Mm-hmm. And I think you mentioned about general anesthesia for a child. How would you explain that to the parents? Is it safe? And
Mm-hmm.
I mean, just different options for the parents. How would you explain that in a way that they will accept it?
Yeah. So like I said, that behavior rating scale is really important. Also, I take into account their anxiety, their medical history, their age. Lots of different factors go into it. But ultimately, every parent's going to want their child to be safe while they're getting dental treatment. So that's ultimately what it comes down to. And I only make that recommendation if I think that the child is going to need it. And as I also mentioned during my presentation, there are varying levels of sedation. So you can do treatment just with the local anesthetic. You can do it with the nitrous oxide, which the only side effect of that really is that you can get a little nausea. So that's why we recommend not eating before. Then there's the oral sedation, which is where they'd be drinking a medication. And sometimes they can also get nitrous oxide with that. So with that, the oral sedation, they're still awake, but they're going to be much more relaxed than with just the laughing gas. And then there's the general anesthesia, which is where we would also have an anesthesiologist in the office who's doing just the anesthesia portion. And I, as a dentist, am just focusing on the dental treatment. So I would say the general anesthesia, even over the oral sedation, is actually more controlled because we're monitoring so much more during the general anesthesia. And the anesthesiologists, they're under really strict guidelines. So they have to have all that backup protocol available if anything is going to happen. And as I mentioned, it's all about case selection as well. So if we have patients who have like heart conditions or certain things that they don't think it would be safe in our office, we have them go to the hospital to get their anesthesia done, just in case anything were to happen. We have that whole code team there as well. So it's all about case selection. And we always want to make sure the parent feels comfortable too. So just answering all their questions before they set up that appointment.
Thank you. And do you think it's possible to use nitrous oxide alone without any other type of anesthesia to perform the procedure?
Yes, definitely. Sometimes I'll even do fillings with just nitrous oxide and without local anesthetic, depending on what treatment needs to be done. We can even do cleaning visits with nitrous oxide for our children that have a gag reflex or they're really nervous. So it's definitely a good option to have the nitrous oxide alone as well.
Hmm. And what is the most severe trauma cases that you have seen in your clinic?
I mean, I've seen everything from multiple teeth getting knocked out to jaws being broken. The one that always sticks out in my mind is my very last patient of residency came in he was at a summer camp and they were playing baseball essentially, but they were using a football instead of a baseball and they were using a bowling pin instead of a baseball bat. And so the first kid that went up, the bowling pin came back after he hit the football and knocked his mouth. And so his teeth got knocked and his braces got stuck in his lip. And so he had to come in so that we can numb him, remove everything, and straighten out his teeth again. He was actually fortunate in that he had braces. So otherwise, I
Yeah.
think his teeth would have been knocked out.
Hmm. And we have the last three questions.
Okay.
And at what age should a child be introduced to high fluoride content product?
So high fluoride, I'm imagining more of like a prescription toothpaste. We don't recommend that until they're over 6 years old and they can definitely spit. A regular over-the-counter toothpaste has more like 1,000 ppm. Again, when the child can spit. We say though that a lot of patients, if they're using the correct amount of toothpaste, they can start using fluoride toothpaste as soon as their first tooth comes in.
Hmm. And at what age is X-ray safe for children?
Again, it's case specific. It all depends on if the child needs x-rays. I mean, sometimes we'll have like 1-year-olds that need general anesthesia because they have baby bottle cavities. And so we will take one x-ray once they're under general anesthesia. Again, we have the digital x-rays and the lead aprons and everything to make it as safe as possible. But I don't think there's a certain age that the risk changes.
Hmm. And the last question is it worth doing a zirconia crown with temporary dentition?
Again, case specific, and also sometimes it's very important for patients or parents to have that aesthetic appearance. I know personally, I wouldn't want silver teeth, especially as a child when they're learning to speak, forming friendships, reading facial expressions. So I always do the white restorations on the front teeth at least. Some parents, again, it just depends on what the patient and the parent values, but it can definitely be worth it. But like I explained, there are risks of fracturing, especially if they're grinding their teeth as well.
Got it. Thank you so much. I think that's all we have for today.
Great.
And for the viewers, we will put the quiz link in our link tree. So remember to fill the quiz out. Thank you.
Thank you.